screening recommendation for HIV?
بسم الله الرحمن الرحيم. Mr. Chairman. دايما بكون سعيد الحظ مع حضرتك بتقديرنا خطر اظن حضرتك اللي هتبتدي في عمان فدائما سعيد الحظ. First of all, I'm very thankful for Professor Hisham Al-Ghazali and Professor Osama Hetta for this kind invitation, and they asked me to talk about the screening for hepatocellular carcinoma. Just a few slides on the global and local incidence of the hepatocellular carcinoma. HCC, as we all know, the third cancer-related mortality worldwide. It's the fifth common malignancy in males and the ninth among females, and the main cause of mortality in cirrhotic patients. It's either low, with an annual incidence from 1 to 3 per 100,000, intermediate from 3 to 10, or high above 10. Was the situation in Egypt before last year? We thought that we have an incidence of 13 per 100,000. This is the data of the National Cancer Institute in 3 governorates, in Damietta, Minya, and Aswan. In Damietta, liver cancer is number 1 among males and number 2 in females after breast cancer. And the overall age standardized incidence ratio is 61.5 per 100,000, which is a very high incidence. In Minya, still liver cancer is number 1 in males and number 2 in females after breast, but the overall age standardized incidence ratio is 25.8 per 100,000. In Aswan, liver cancer is number 2 in males after bladder cancer and number 3 in females after breast and ovary, and the overall incidence is 13.1. In Saudi Arabia, it's 4.2 per 100,000. This work was done by late Professor Rahman al-Zayadi, and he said that the incidence increased among a decade, 2-fold increase, starting from 1993 till 2002. This is our work in the hepatoma group. We started in March 2002. We started with 122 cases as a total number. In 2014, we reached 2,087 cases, total number of cases per year. We started with 56 new cases per year when we started, and in 2014, we reached 571 new cases. This is the distribution of our patients at presentation. We have 25 of our patients stage A BCLC, and 20% B, 40% C, and 15% D, which means that only 25% of our patients at the presentation have a chance for cure or curative treatment, and the rest are going to have either palliative or best supportive care. So that's why we are talking about surveillance, which means early detection and better outcome. This is the natural history of cancer. We have only a very small area for cancer control window. Screening is one-time application of a test at a stage when intervention may significantly improve the natural course and outcome, and the surveillance is the repeated application of the test over time. Criteria for surveillance: first of all, the disease must be a common disease with substantial morbidity and mortality. We should identify the target population. There should be an acceptable screening test with low morbidity and high diagnostic accuracy, with a well-defined report strategy, and overall, we must have an effective therapy and diagnosis. These are the target population according to the EASL: the chronic hepatitis B, chronic hepatitis C, and all the cirrhotics. According to the American Station Study of Liver Disease, chronic hepatitis B, chronic C, they don't do surveillance for them, and the cirrhotics. According to the Japanese Society of Hepatology, chronic hepatitis B, chronic hepatitis C, and the cirrhotics. According to the Egyptian Society guidelines, we also have a target population of the chronic hepatitis B, chronic hepatitis C if they have a Medavir score 3 or 4, and all the cirrhotics. The ASLD guidelines recommend the surveillance for HCC to be performed by ultrasound, and the patients should be screened at 6-month interval. Surveillance interval does not need to be shortened for patients at a higher risk. The rationale for surveillance, a prerequisite of cost effectiveness, disease frequency, the target population should be sufficiently high, and several cost effectiveness models for HCC have proven that HCC surveillance is cost effective. What about the development of HCC in cirrhosis? It varies in several studies from 1.4 up to nearly 7% per year. The screening interval for HCC depends on the doubling time versus the tumor diameter, and from this figures we see that the 6-month screening interval is an optimum duration for the screening. In Egypt we have the hepatitis C virus genotype 4, and the surveillance test is the abdominal ultrasound plus alpha-fetoprotein, because alpha-fetoprotein increases a little bit in the sensitivity of the test, and we'll show the pattern of the alpha-fetoprotein in our patients in the following slides. Diagnosis of hepatocellular carcinoma depends on the target biopsy, the alpha-fetoprotein, and the imaging techniques. In our data in the hepatoma group, criteria of diagnosis in 2,783 patients, we did biopsy in 2%, we depended on alpha-fetoprotein in 1%, imaging in 60%, imaging plus alpha-fetoprotein in 38% of patients. This is the pattern of alpha-fetoprotein in the same number of patients. In 19% of our patients, it was a normal alpha-fetoprotein. In 81%, it was above 10. In 46%, it was above 200. And in 20%, it was above 1,000. In a study performed by Lay, Professor Abdurrahman Zayadi, in 2010, they found that surveillance increased the early detection of HCC, and it doubled the chances for curative options. This is the largest randomized controlled trial performed on surveillance. It was performed in China on 18,816 hepatitis B positive patients recruited. The surveillance was performed by ultrasound every 6 months plus alpha-fetoprotein. The adherence to the surveillance was suboptimal, less than 60%, and they concluded that HCC-related mortality was reduced by 37% in the surveillance arm. This study was performed in Minofeya Liver Center. Dr. Tabahat presented in Washington, D.C. in the ELCA meeting in 2013. They started the study by 1,920 patients. 1,286 patients came for the first and subsequent follow-up visits, and the compliance with the screening program was 67%. And they concluded that hepatocellular carcinoma screening with ultrasound and alpha-fetoprotein is feasible, acceptable to patients, effective, it detects patients at earlier treatable stage, and it is cost effective. And they said that screening for HCC is an essential national program that has to be sponsored by all treating bodies, including MOH. And I think that last month, the MOH launched a surveillance program for HCC, for colorectal malignancy, for bronchogenic carcinoma, and for bladder and prostate cancer. They started a program which I think is going to be going on in the near future. After we detect the focal lesion by screening. This is the algorithm for what's to be going on after that. If the lesion is below 1 centimeter, then the ultrasound should be repeated at 3-month interval. If there is growing or changing in the character, it will shift to the other arm. If it's stable for 16 to 24 months, then he's going to be in the surveillance program. If the tumor is above 1 centimeter, then a 4-phase multi-detector CT dynamic contrast will be done. If it shows the typical picture of arterial hypervascularity and venous washout, this is okay for HCC and is going to be treated. If not, then an MRI should be performed. If it's okay, given the picture of HCC, it's going to be treated. If not, a biopsy should be performed. The performance status of the patient should be counted. And lastly, the patient will be put in any category of the famous BCLC, if it's stage 0 or stage early stage, or stage A, stage B, or the C, or the end stage. The best supportive care is going to be allocated for whatever treatment according to his condition, which is according to the liver status, the tumor status, and the performance status. Thank you very much.
Our dear Professor Dr. Mohammed Shakir, thank you very much for your very informative talk and presentation. And we can allow for one question from the floor. If we...
Thank you very much for this elegant presentation. Will you recommend screening for high-risk patients regardless of their age, or you think you need a certain age group?
Nowadays we see HCC in younger population. So if he is cirrhotic, I'm not going to wait until he is 50 or 60 years old. Putting into consideration that the mean age is around the 50 or 60. But we have patients in the 30s and 40s. So if the patient is cirrhotic or the patient is chronic hepatitis B with a family history of HCC, I don't think that we should wait for him till he reaches 50 or 60, then we're going to start the screening.
Okay, so because of time, we can restrict one question to each speaker. Thank you very much, Professor Shakir. And I have the honor to pass to the second speaker. We have the honor to have our American-Egyptian guest, Professor Dr. Ahmed Kasib. Ahmed Kasib is a very pioneer and very famous name in the region of HCC and molecular biology, as well as a very novel therapy. And so Professor Dr. Ahmed Kasib will deliver a talk, Immunotherapy in Hepatocellular Carcinoma, Strategy for the Future. Please, Dr. Ahmed.
Thank you very much, and it's a privilege to be here every year. I enjoy coming back to visit with my colleagues and my professors who taught me everything I know about medicine. So the talk today is really a timely talk in terms of immunotherapy era that we're experiencing nowadays. So Dr. Shakir did a great job covering the background, epidemiology, all of that. So I knew that even before I came, so I'm going to jump right in here. This is my research support in terms of clinical trials. So it's part of the cancer moonshot. It's actually the theme of the cancer moonshot as announced by the NIH and President Obama last year. And this is because it's an innovative target. And not only that, because we have very little progress, even experiencing almost two decades of targeted therapy, and we just have a handful of approved agents in cancer in general. So I'll start with a snapshot at the current treatment guidelines, what are the options available, and then I'm going to move to the pathogenesis of the immune cell pathway, and then discuss opportunities and challenges to immunotherapy in HCC, list what we have available at MD Anderson and what we could collaborate on, and then conclude. So it's very simple when it comes to HCC. very few options are approved and found in guidelines. Liver transplant came along in 1996, and then ablation a few years later, and then TACE, and then sorafenib with the only systemic therapy approved for frontline. And just a couple of weeks ago, there was a press release about regorafenib, a phase 3 study that met its primary endpoint. So its second-line therapy was 2-to-1 randomization against placebo. So we're going to hear more about this in the next few months. So let's move quickly to the pathogenesis of immune cell pathway and HCC. So there is a big rationale when it comes to HCC for immunotherapy. The liver organ is by definition an immune-tolerant organ, and that means because it's a filtering system, so the immune cells are always turned off. So this actually facilitates development of HCC, and also gives a big rationale to use immunotherapy in this setting. So Tregs are overexpressed, specifically certain phenotypes of T lymphocytes, regulatory T lymphocytes. This is one of them, CD4, CD25, FOXP3, and CD8 as well. And then we also have other cells, including PD-1 expressors, T cells. So it's an overall theme of chronic inflammatory cascade that eventually leads to HCC. So if you want to break it down according to the risk factor, whether hepatitis B or C or even NASH-related HCC, you really go through acute phase and then chronic phase. This is just an example of the viral-related immune phenomena. So in the acute phase, there is a chance that you have a potent immune system and then the virus will be cleared. However, with the persistent infection, chronic infection, specifically hepatitis C, of course, there is persistent antigen stimulation. So this will lead to inhibition of the effector immune cells and loss of the tumor, what we call tumor surveillance, and then eventually cancer progression. So this is a closer look here to dissect what we just talked about. So on the left-hand side, you have the multiple risk factors here, all these predisposing factors, whether hepatitis or NASH or even autoimmune phenomena leading to liver cirrhosis and then eventually HCC. And along the line, you see increased expression of cells that have a phenotype of PD-1, T cells expressing PD-1, and then you have increased number of suppressor T helper cells, and then you see some changes in the regulatory T cells to change its phenotype. And once the phenotype changes with certain receptors, then the function will change. So it's really a very complicated process for hepatocellular carcinoma in particular, which is not very similar to other solid tumors, because as we said, this is an immune tolerant organ, so the environment is not the same as it is in colon or lung. And then you also have some cytokines involved, either stimulatory or inhibitory cytokines, to make it even more complicated. This is just a closer look at one of those cells that we just mentioned, which is the regulatory T cells here. So these are different phenotypes here, and to make it even more complicated, it's actually not the majority of the cells in terms of percentage. So overall, if you look at the Tregs, it's about 5%. In all tumors. And then when you look at the T cells, you have to be able to discriminate. Is it a native T cell coming from the thymus, or it's the inducible T regulatory cells coming from the tumor? And then you have the peripheral versus tissue immune cells related to Tregs. So this is just focusing on one small subset of immune cells, and you can appreciate how many phenotypes, and everyone will change its function. So in order to be able to control this phenomenon at the molecular level, you really have to come up with multi-targeted agents. Anti-PD-1, for example, is one of them, but however, you really have to be able to come up with different strategies of combined immunotherapies, combined immuno and targeted therapy, combined immuno and local therapy. So to summarize what we just talked about in terms of the hepatitis in immune-related phenomena here. The basic fact is the hepatitis virus replicates in the hepatocytes and escapes the immune elimination and then turns into chronic inflammatory cascade and then persistent antigen presentation as we spoke about. And then eventually it induces multiple cytokines, including the most famous ones, interleukin-10 and TGF-beta, to expand the T regulatory cells. So as we mentioned, the baseline state is about 5% of the regulatory T cells. However, with the chronic inflammatory cascade, certain interleukins, specifically interleukin-10 and TGF-beta, would lead to expansion of those T regulatory cells. And then you have specific impairment of the dendritic cell function, which also leads to expansion of T regulatory cells. So let's summarize this here in one slide. So on the left-hand side, we have the upregulation of inhibitory cells, which basically expresses the PD-1, among others, TEM and LAG, CTLA-4. You have increased suppressive cytokines. We just talked about interleukin-10 and TGF-beta, which both of them and others would lead to increase and expansion of the regulatory T cells or Tregs. And then you have eventually downregulation of cytokines, other phenomena, which is the co-stimulatory. So you have downregulation of those cytokines, interleukin-2 beta, and then interleukin-7 or alpha. We actually looked into that at MD Anderson from 270 HCC patients, 60 surroundings, 100 controls, and looked into those specific cytokines that modify and modulate the environment for immune cells, and we validated those results as well. So let's move to opportunities and challenges to immunotherapy in HCC. So I'm going to use what we just spoke about in terms of pathogenesis as a stepping stone, and then talk about how we can design clinical trial approaches to address this innovative pathway. So it's important for us to know that it is really not that new. It's been around for decades under different names. We just didn't understand this was an immunotherapy. So if we look at all studies looking at interferon, for example, in a sense it is an immunotherapy studies here, and we have some conflicting data, and survival did not pan out to approve any of them. And this is probably was most likely related to patient selection, because those patients were patients with end-stage cirrhosis, so they didn't handle those cytotoxic therapies very well. So let's have a closer look here at immunotherapy opportunities. So CTL-mediated tumor killing, we spoke about that. We also spoke about immune suppressive cell elimination through focusing on T regulatory cells. Adaptive cell therapy is also a very innovative approach, which has been tested also in hepatitis B, specifically in Asia. We have a few slides about that. And then, of course, cytokines, as we alluded to, interleukins and chemokines that modulate the immune cell activation. And then immune checkpoint blockade, which is basically most of the clinical trials are addressing this pathway now in terms of anti-PD-1 and CTLA-4. So how about other local therapy approaches combined with immunotherapy? We spoke about the local therapy, and we're going to break them down now. So radiation therapy, this is a study that looked into a review of the tumor microenvironment after radiation. So the main aim of the study was to look into mechanisms of resistance and recurrences, and of course the hypoxia effect and the tumor recurrence around the treated area that we all know about. However, they also looked into the immune targets, and they actually showed some beneficial immune modulation at the tissue level after radiotherapy here, and they have very specific literature review about the mechanisms behind that. So classification of immunotherapy then would fall into big categories. On the left-hand side, you look at mainly treatment options that reduce the tumor burden, like local therapies as we have here, RFA, TACE, and TARE, and I would also say radiotherapy here. And then you have the three main pathways here that are heavily tested nowadays. We have the vaccine pathway that enhances the T cell priming and expansion, anti-CTLA4 as we spoke about, that eliminates the T regulatory cells, and then a big category of the anti-PD-1 and PD-L1, which basically kind of a release of a break phenomena to regain the activity of the immune cells. And then the rest of them are also being addressed in combination with other targeted agents and chemotherapy. The one on the far right hand side here, anti-VEGF, we're going to talk a little bit about that in another slide as well, in addition to chemotherapy combinations and mechanisms of synergy between them. So this is a closer look here at the tissue level of the activating and inhibitory signals. So PD-1 here is an inhibitory signal that we seek in terms of clinical trials to release the brake and then activate the cells. And there are some beneficial stimulatory mechanisms like OX40 agonist mechanisms and CD40 agonist as well. This was presented at the ASCO last year, an oral presentation that looked into the first study that really showed a signal for HCC using anti-PD-1. So this is a nivolumab and showed a decent, about 22%. It was a small study, phase 1/2. However, it led to expanding this study to randomized phase 2 and randomized phase 3 studies to address this pathway in HCC. So this is what's either pending or ongoing along the same line of the PD-1. So there is a plan for pembrolizumab, which is another anti-PD-1, phase 2 and phase 3. There is other agents here along the same line. All of them are in the different stages, but you will see more of phase 3 studies when it comes to PD-1. So nivolumab and pembrolizumab specifically. And then another approach, as we mentioned in this slide of the strategies in the vaccines. So we have different strategies here to come up with the vaccines. We either have to dependent on tumor-specific peptides or proteins or DNA, live attenuated vectors, and then you either use it alone or combined. You can use it actually in different settings, such as metastatic or even adjuvant. So in terms of adjuvant, you will take the isolate of the resected tumor and then formulate a vaccine against the antigens of this tumor, and then give the patient the vaccine to formulate the antibodies against that tumor. So these strategies are being conducted heavily in Asia. Actually, they reached phase 3 in some of them. So dendritic, under vaccination, you have different categories. The most famous one is dendritic cell vaccination here. So this was just, kind of small studies looking at signal activities here, and it showed some signal of activity, some stable disease, and some response rates. But currently, they're moving to larger studies. None of them has been validated yet. And then if you look at the vaccination studies in the US, currently there's only one phase 3 study that is still pending to be open and with overall survival as primary endpoint. When you look at cell-based ongoing immunotherapy, mainly in Asia and mainly invested in the adjuvant space, because basically in Asia the difference is they have more patients with preserved liver functions, so they are more aggressive and they have a big room for surgeries. So the main problem in Asia is different from Egypt and the US. Over there, the main problem is the tumor recurrence. So most of their immunotherapy studies are focusing on this space here and that's why you will see the primary endpoint is recurrence-free survival, or RFS, and they have a lot of phase 3 studies going on in this area here. So hepatitis B in natural history is different, so they have higher chances of getting the resection, but then they have higher recurrence rates. So this is a summary of the evolving strategies of combining immunotherapies in HCC. So they revolve around increasing the lymphocyte infiltration inside the tumor to recruit the cells and then use the immunotherapy subsequently. They also look at activation of the primed T cells and also attenuation of the immune suppression in the tumors through attacking the specific receptors we mentioned. Among them is PD-1 and PD-L1. So let's take a snapshot at one modality, which is radiotherapy here. So to understand this, I put some arrows here to make it easier for us. So for example, radiotherapy here would increase the lymphocyte infiltration inside the tumor and would also enhance the activity of the antigen-presenting cells. So it would be best for immunotherapy clinical trial combinations to combine them with immunostimulatory antibodies because of this lymphocyte infiltration. So you're recruiting the cells and then you can use antibodies against them. You can also use cancer vaccines since you have antigen-presenting cells here. So this is just to simplify it, and then you can go down to the next chemotherapy and so on, the same phenomena. So you see what chemotherapy does, and then you look for the right agent to combine it with. So there's a couple of examples here quickly about overcoming the mechanisms of resistance here. So for example here, using adenovirus expressing interleukin 12 with a systemic therapy with the anti-PD-1. So the challenge here is systemic infusion of interleukin 12 is very toxic, so you want to be able to do it at the local tissue level. So you inject the toxic agent inside the tumor itself to help overexpress the cells and so on, and then you have the PD-1 administered systemically. So the rationale for combining the viral vector here as a local modality and systemic is the toxicity. And then you have another strategy here, another example looking into a similar viral vector adenovirus expressing CL10 combined with adaptive cell therapy. So the challenge here to adaptive cell therapy is the poor penetration of the effector cells, so you use the viral vector to facilitate that. So a few studies here as an example about the non-cell based, and most of them are showed no survival benefit. The largest again was from Asia, focusing on resection. And then a few slides here left about the emerging biomarkers of clinical benefit or toxicity from immunotherapy. So there are a lot of studies that looked into serum biomarkers such as LDH, C-reactive protein, VEGF, cell assays like absolute lymphocytic count. So this was found in melanoma at week 7 if it is more than 1,000 to correlate with benefits. So this is just a snapshot at where the field is moving to identify patients who could have better benefit or higher chances of side effects. So uncovering immune modulation effects of targeted therapy is another area. We spoke about that, anti-angiogenesis here, which could lead to dendritic cell maturation, for example. And then we have to be able to understand that with immunotherapy, the tumors could get larger before they get smaller. So we have to use immune-related response criteria and also compare it to the RECIST criteria in clinical trial design. So let's summarize it here. We want to be able to personalize immunotherapy approaches for each single patient. So the best way of addressing that is to analyze the tumor with what we call immune profiling. So when you do the immune profiling, then you can characterize the tumor if it's an immunologically responsive tumor or unresponsive tumor based on, as we mentioned, the regulatory T cells, for example, and certain receptors. So a big example here is what we learned from the colon story until we reached a point where we knew which subset of patients that could benefit here. So the last couple of slides about what we have at Anderson. So we have an anti-PD-1 study for all comers after sorafenib. We have another one combined with hepatitis C drug and hepatitis C related HCC, and then the third one, and this is biomarker strategy, is nivolumab, randomized study, and then OX40 agonist. So let's conclude here. So immune cell emerges as a new innovative target in HCC. Exploring those targets is high priority, and discovery and validation of the immune pathway subclasses is very critical to personalizing therapy approaches for those patients. There's a big promise to combine local and immunotherapy, and therefore international collaboration is really critical here to help us focus on specific subgroups, and I would mention, of course, hepatitis C in particular for the Egyptian patient population. So thank you very much for your time.
Thank you, Professor Ahmad Kasib, and I think we have time for one question.
Professor Ahmad Kasib, Thank you very much for this very updated and enthusiastic presentation. Now, are we on the era of prognostic factor for hepatocellular carcinoma, infiltrating lymphocyte, tumor infiltrating lymphocyte, and either it is stromal or it's a tumoral? I would like to apply the rule from breast cancer to HCC, or we are yet very far from this era?
Yeah, that's an excellent question. So we looked into immune profiling for our patient population. So our breakdown is about 30% hepatitis C, 10% Hep B, and then about 30-40% NASH, and then the rest of them are unknown. So basically, we found very different immune profiling for every specific kind, even within the same risk factors. So depending on the duration of the chronic inflammation and the specific risk factor, whether it's Hep B or C or NASH. So you really have to be able to do immune profiling first to identify, as you said, the stromal versus the tumor. Within the tumor itself, you actually have to look into the central versus the peripheral. So all of these factors are going to affect your choice of immune therapy. So that's why I think we're at an era now where if you have available tissues, then they have to be fresh tissues. So of course, Dr. Amran, our surgeons, it would be very important to collaborate with them, because these tissue biopsies, you really have to be in the OR to drop them and get them in a fresh state to be able to do immunoprofiling. And then you have a pathologist. So it's really multidisciplinary research team to be able to do this immune profiling. The big advantage here in Egypt is that you have more homogeneous risk factor, which is Hep C, even much more focused, which is genotype 4. So this is a big advantage, and definitely you should start by doing immune profiling. That way you know exactly what the landscape is looking like, and then you can stratify patients based on the immune profiling, and that will help you to choose which modality to start with or combine.
Thank you, Mr. President. It is a little bit theoretical question. Suppose that you have a patient with HCC with an underlying active HCV. Would you like to start by antiviral therapy for improving the immune state of the patient, because it may be more responsive to immunotherapy or not? Thank you.
So that's a great question. I see Dr. Ashraf here, and he's got to talk specifically about this. So from my standpoint, I think we really have to do it in a clinical trial setting, because we don't know what's going to happen. So one of the studies I listed here that we're opening is anti-PD-1 immunotherapy plus hepatitis C. So the big advantage here, and that's why we were able to get it quickly, both drugs are from the same company, which is Merck. So unfortunately, this is one of the practical things that we have to deal with in reality. So you have to be able to combine immunotherapy with antiviral, but the problem is, if it is a different company and the agreements and so on. So I think there is a room for doing that in a clinical research setting. Right now, the only approved indication for Hep C in the US for hepatocellular carcinoma patients is for those patients waiting for transplant. So you want to clear the virus before taking them to transplant, or for patients who underwent curative therapy. So either resection or ablative radiation. So if you have a patient who is technically cured or waiting for transplant, this is the only patient population who treat with hepatitis C drugs.
Okay, thank you, Professor Ahmed Kasib. And again, it's our pleasure to listen again to our Arabic American guest from Illinois, USA, Professor Riyad Salem, who is by far the most expert doctor all over the world in the using of wide band radiation beats. You speak about radioembolization in HCC.
Thank you again, Mr. Chairman, for the invitation to talk about HCC. I'm proud to represent the American, Syrian, Canadian contingency at the meeting, so thank you for the invitation. I do have some disclosures. So what I want to do is sort of give you the update and the state of the science of radioembolization for HCC. And I know Egypt is certainly one of the premier centers in the Middle East that is practicing this. And the first thing I want to highlight when we talk about this is the difference between radioembolization and chemoembolization. And radioembolization is a microembolic treatment. You are not including the blood vessels. It does not induce the classic post-embolization syndrome, the pain. And as a result, these therapies can be done on an outpatient basis. And so at our center, patients are discharged 2 hours after the procedure. Same day procedure, outpatient. That's a very big advancement. There are now 4 large phase 2 studies that have been published in very sort of prominent journals when you talk about Y90 for HCC. And the data can be replicated. And one of the co-authors here, Ahmed Al-Fouli, is here that had worked on this kind of data. So the data can be replicated, and the outcomes are quite compelling. I'll share that with you today. In terms of the data that we have, I want to show you the evolution of how we came to where we were. And one of the early series that we looked at is the downstaging to transplant concept. Can you take a patient outside transplant criteria and downstage them to make them transplant candidates and then list them? And this is what we looked at years ago, and it was a small series, 35 patients. We had only transplanted 7 patients at the time, but what we started to do is starting to do the radiology-pathology correlation. Because we have nice imaging that you see on MR and on CT, but the gold standard when you're looking at necrosis and tissue is pathology. And because we're transplanting people, we perform these radiology pathology concordance studies. And what we found was that when we looked at the CT scan or the MRI before transplantation, and we interpreted whether this tumor was dead or had viable disease, we were only right 2 out of 7 times. Which means you're wrong most of the time when you interpret the imaging study in terms of viable disease or completely necrotic tissue. That's a problem, because most patients do not get a liver transplant, and our only standard in terms of how to follow patients is by imaging. This is one of our early cases where you can see a dome lesion, treated with Y90, necrosis smaller, but had irregular nodular enhancement. Irregular nodular enhancement implies viable disease, and so we wanted to retreat this patient. When we brought him in, he got a transplant before he was able to get retreated, and at pathology, it had complete pathologic necrosis. Viable disease on CT scan, or our interpretation, but complete necrosis at pathology. So this is a very important thing. So this led to our Y90 sort of rad path correlative analysis comparing to chemoembolization, which is the gold standard for this patient population. And what we found by comparing a 35 patient Y90 set of transplanted patients and 35 transplanted chemoembolization patients is that if you look at necrosis and the ability to kill the tumor, Y90 outperforms chemoembolization for tumors 1 to 3, 3 to 5, and greater than 5, they are equivalent. So there's work to be done with both treatment modalities when you have very large tumors, but at least at the microscopic level, the necrosis level, it appears that Y90 outperforms chemoembolization when it comes to pathology tissue, and if your goal is to achieve complete path necrosis. Now these are some compelling images, and I'm showing you sort of my best cases, but they're very large tumors. And one of the things that we learned, and we know this from the radiation oncology literature, is that you should always have your baseline scan, particularly in HCC, on one side of the screen, and look at your follow-ups on the right-hand side. Because you will see here, as you can see in this case, the 1 month follow-up looks no different. And the 3 month, you're starting to see some effect, and 6 months, and 10 months, and 15 months. And you always have to compare to your baseline scan, because if you only compare to the scan 2 or 3 months before, you will miss a 3 to 4 to 5% reduction and miss the response. This is the best case that I've ever had. This person was treated in 2006, 1 treatment to the right lobe. This is before sorafenib. You can see a very large lesion with multiple satellites and hepatic vein invasion. We did a right lobe Y90, 1 treatment. He came back 1 month later, looked like this. We had no clinical trials, no sorafenib, etc. So all we could do is observe the patient. This is at 1 month. He comes back at month 3 and he looks like this. 1 treatment for right lobe. The hepatic vein is now 8. We now have 1 year follow-up. It's much better. 16-month follow-up and 22-month follow-up. We have 4-year survival on this patient. 1 treatment to the right lobe. So the potency is there when you can select the right patient. But this pre and post image is quite dramatic. 1 treatment to the right lobe, outpatient. So we have to find these patients. Here's a patient with a 10 centimeter segment 1 tumor with an AFP of 2200. I think we will all agree that at 1 month, the scan looks no different. You can see that the lesion is the same size. It still has enhancement, but the AFP has gone down by 90+%. And so by imaging, this is lack of response. And we have to, when we do Y90, observe this patient at this time because we know it's microembolic. And it often takes about 3 months to see the full response. So we wait. And the AFP here is helpful to show that clearly the patient responded. At month 3, it looks like this. And at month 6, looks like this. That was one treatment to the right lobe, and the patient was downstaged from T3 to T2 and was transplanted. One treatment to the right lobe. So very dramatic response when you look at it. The data, the four phase 2 trials that I discussed, two very interesting concepts emerge when you look at Y90. One of them is called radiation segmentectomy, the other one is radiation lobectomy that I'll talk about. This is a multi-center study that we did with Mount Sinai in New York. And the idea of radiation segmentectomy are patients that have a small segment of liver that bears tumor that may have some small microsatellites, but where you can implant in one shot a very high ablative dose of radiation. So this is 102 patient series that we looked at with Mount Sinai, and you can see here that we stratified and looked at all of our transplanted patients because we wanted to continue this whole radiology pathology correlative analysis, and we learned several things. First of all, just because you have an M-RECIST CR doesn't mean that you have a CPN, complete path necrosis. And just because you have partial necrosis here in pathology doesn't mean you're not going to have an M-RECIST CR. So the obverse and the reverse is still true. So this is interesting. M-RECIST is certainly not perfect. But because we have radiology pathology correlation and we have transplants, we decided to hunt for the dose, the threshold dose, that will allow you to achieve complete path necrosis. And we found that if you implant 190 gray in one setting, in one shot, in the arterial distribution, you will achieve complete path necrosis. So this is very important because this is called threshold and predictable dosimetry. So now we target 190 or 200 gray when we're doing radiation segmentectomy. Segmentectomy looks like this. You can see the wedge of liver being perfused, you can see the tumor, and you can see multiple small satellites. So you cover the whole territory with an ablative dose. 2 cases, a lesion high up in the dome that we could not see with ultrasound, that was treated with segmentectomy at month 1. And you can see the radiation effect here along the arterial plane and no radiation effect anywhere else. You can see the lesion is smaller. This is a 95-year-old woman that we treated with a large 4-centimeter lesion, but was perfused by segments 6 and 7. You can see the 1-month scan. You see the radiation effect here with nothing elsewhere in the liver. That's at month 1. Month 6, it looks like this. So you can see the whole segment starts to atrophy. And you can see that the correlation, the AFP went from 950 to 5. Very nice result. She's now 98. We have 3-year follow-up on this patient. And you can see the segmental area that was radiated. One treatment, outpatient, not like chemoembolization. We have a lot of surgeons in the audience, and one of the interesting concepts that we're now talking about here with Y90 is the concept of radiation lobectomy. And what is radiation lobectomy? Radiation lobectomy is a concept that is meant to sort of challenge or potentially replace portal vein embolization in a patient that would otherwise undergo a curative surgery. So by default in HCC, they're Child-Pugh A. They are resectable, but maybe inoperable because of a small future liver remnant, such as this patient right here. And you can apply this concept with CRC and neuroendocrine, et cetera. Here we're talking about HCC. The problem, of course, with surgical resection is high recurrence rate. So what do? One of the issues that we have with portal vein embolization, which is the traditional way to hypertrophy livers, is that one is, if you look at the PVE data, you don't usually have time-dependent analyses. You do a PVE, you have a 1-month follow-up, and that's it. You don't know what happens at month 3, month 6, month 9. We need more time-dependent analyses with PVE. Most of the PVE data is with CRC and very little in HCC, and in fact, some people believe cirrhotic livers do not hypertrophy and have in fact completely abandoned PVE in HCC. So there's limited intention to treat data. What happens when you have 100 PVEs that you do? How many end up in the operating room? And then what happens to patients that you do PVE and don't undergo resection? These are data that we have to look at. And I look at this is the largest series from MD Anderson. This is CRC, not HCC. And so I acknowledge the limitation here. But this is 360 patients undergo PVE, but notice that only 280 go to the OR, 76 have canceled resections, and only 240 undergo resections. So you've done PVE, an invasive procedure, all sorts of things, and you actually aren't able to resect everybody, and we know that's one of the limitations of PVE. And it can have, at least in this patient population, some major post-hepatectomy complications. So you can imagine, if that's the CRC patient population, what might happen if you resect the wrong HCC patient. So possible reasons why radiation lobectomy is interesting in HCC over PPE is it treats the tumor. The Y90 treats the cancer. It embeds and mandates a biologic test of time. We know that transplanting a patient, if you wait 6 months, you'll get better outcomes than if you see a patient and transplant them very quickly because you know the biologic test of time. It generates very high rates of FLR that I'll share with you. It also permits you to treat portal vein thrombosis patients, and I'll discuss this. So the first thing is it treats the tumor. I've shown you many cases where the lesion gets smaller. You actually are targeting the cancer. And if you look here, the time to hepatic decompensation is 35 months. So if you choose a Child-Pugh A patient and you do lobar Y90, they don't really decompensate. You've got plenty of time to do and prepare for your surgery. So that's an important thing. It mandates a biologic test of time and generates hypertrophy. Why is that? Because some time must elapse before you see the tumor response, showing good biology, and simultaneously the FLR. So here with this time-dependent analysis, the tumor got smaller from 134 to 56 cc's. The parenchyma did not change, but the left lobe did hypertrophy, and we got an FLR up to 45% at month 9. It does take some time, but again, if you wait a few months, you are probably hyperselecting and you're going to get better outcomes with your HCC patients. So this is something that is beneficial. This is a patient with multifocal HCC, small FLR that we did Y90 on as a radiation lobectomy, hypertrophied the left side, and underwent a curative right trisegmentectomy. This is of interest when you have limited transplant availability. Another example here, pre and post underwent curative right trisegmentectomy. And these data have been replicated by the Spanish group, the French group, the German group. The FLR will increase in size and the treated size of the tumor will get smaller. So this is something that is very interesting. Recently, we just published this in the Journal of Surgical Oncology, the radiation lobectomy concept, which has become effectively our institutional standard of care. We will treat this way now everyone before surgical resection or potential resection for HCC. And so we have a median time to resection of about 86 days. So that's 3 months, that's pretty good. And hypertrophy rates that are very compelling in the HCC cirrhotic patient population. This is what one of the patients looks like in the OR. Notice the right lobe has a lot of disease, and the left lobe, segment 2-3, clean and in preparation for his right trisegmentectomy. Now, one of the interesting things that we've also observed is we know from the surgical literature, when you do a right trisegmentectomy or so, the phosphorus will go down as hypertrophy is occurring. This happens immediately in the post-op phase, and so you want to see that phosphorus go down significantly post-operatively because it's showing that the liver is regenerating. If it doesn't happen, it means that the patient is about to decompensate or may decompensate. One of the things that we notice in the right trisegmentectomies that we've done in the Y90 patients is that the phosphorus doesn't change. There is no drop because the patient has already hypertrophied. So as a result, what you are doing is it's a beta test, a litmus test that you could use phosphorus as a surrogate for hypertrophy before you undertake the risk of the resection and possibly not compensating for the trisegmentectomy. So an interesting thing that we're now studying, but median phosphorus levels do not change when you do a resection after Y90 radiation lobectomy, and the bilirubin stays steady. Very interesting concept, and we now apply that in our center routinely. The other thing is, there are very limited numbers of liver transplants, as you know, and so it obviously permits portal vein thrombosis. Because it's non-embolic, you can now treat the right lobe, in this case, right lobe PVT. You can see a tumor with PVT. And because you don't have a risk of ischemic hepatitis, you can do this, and you get a good response. As you can see here, a very good response. At 2 years, we have an FLR of 68% now, and in some cases, you can now resect that patient. So this person had PVT extending into the main portal vein, and 2 years later was resected. Good biology, obviously, good response. And now we have almost 1 year follow-up in a patient who has had a right trisegmentectomy after presenting with advanced BCLC disease. So I think radioembolization is an interesting concept for the lobectomy approach. PVT I just described as something that is a niche application for Y90 because you don't embolize the artery. You don't cause or risk ischemic hepatitis. We discussed this, but I show you this slide again because in reality our survival now with branch PVT is about 16 months. So Child-Pugh A branch PVT, compelling survival outcomes, certainly outperform sorafenib, but not demonstrated in a level 1 evidence. QOL, we've done a prospective study showing that quality of life is better with radioembolization compared to chemoembolization. We did this in a prospective manner, and you can see here that quality of life does diminish after chemoembolization and it does not change after radioembolization. There's no reason for it to improve, but at least it does not change. But certainly with chemoembolization, there is an alteration in quality of life using FACTEP, which is the only validated tool. So where does Y90 fit in? There's certainly multiple places. The versatility of the treatment allows you to implant it in multiple places. And there are a lot of randomized clinical trials that are ongoing. Premier, the first one that I'm showing here, we closed, and I'll show you the data. But there are a lot of other randomized clinical trials, head-to-head or in combination, that are using survival as the endpoint, but will have a big problem of crossover. Many of these therapies, patients are going to cross over from group to group, which will make survival analysis very complicated. Now, proud to show you, I think this is the second meeting where I present the the results from our randomized clinical trial comparing chemoembolization to radioembolization. And this is a prospective study that we did. Endpoint, it's a randomized phase 2, so the endpoint is time to progression. And we applied the stage migration concept. We know that early disease patients should be either resected, ablated, etc. But if you're not a candidate for that treatment, stage migration says that you go to the next stage and you go to chemoembolization. And so all BCLC-A patients not candidates for that treatment went to BCLC-B treatment, which is TACE. And of course, all BCLC-B patients get randomized as well because they are TACE candidates. So those are the patients that we had, BCLC-A's and B's. And here's the consort diagram showing how difficult it is to randomize patients to this therapy. A lot of patients want Y90, a lot of patients want chemoembolization, a lot of patients don't want a computer deciding what treatment they're going to have. So at the end of the day, we only had 21 versus 24 patients. And we closed the study at 45 patients at the very strong recommendation or coercion of the cancer center saying that's enough, it's taking you 6 years, let's close the study. So we had blinded analysis. And I'll show you the results. This is a randomized trial, so the groups are very well balanced, as you might expect. But one thing was interesting, we had a little bit more portal hypertension in the Y90 group compared to